Hello, everybody. Happy Tuesday. Welcome to this webinar series. Thank you so much for being here. My name is Glenis Pagan from Filantropía, Puerto Rico, and we are welcoming you to this webinar series that it's a part of a series that started exploring issues related to the earthquakes that began in December of 2019 in the south of Puerto Rico, and now we have refocused and expanded on the needs around the coronavirus disease. We talk in these webinars about the most pressing issues affecting Puerto Rico and focus on analyzing and giving recommendations from different perspectives about these issues. You may visit filantropiapuertorico.online to watch this webinar and previous webinars that we've had, and also to download the presentations. This webinar will be 30 minutes, and after those 30 minutes, we have 15 minutes of questions, of Q&A, which for those participating, at the bottom of your Zoom screen, you have a little icon that says Q&A, question and answer, so you can hit that during the presentation to ask your questions, and then at the end, we'll definitely go ahead and address them. Also, there's a little chat icon, so if you have any comments, you can go ahead and send us anything through that. And we just shared the link of where you can find this webinar and presentations. It will be recorded and it will be sent out to you. Para nuestros amigos de Puerto Rico, esta sesión es en inglés, sí, porque tenemos muchos miembros de Filantropía que son de Estados Unidos y hablan inglés, y queremos que también participen y sean parte de estas conversaciones que hablamos de Puerto Rico, pero pueden hacer todas sus preguntas en español y las estaremos tomando a través del Q&A. So the topic of today is COVID-19, an expert's view on what must happen on the ground. And we have a very, very special guest with us today, Mark Grabowsky, as you can see him. Dr. Mark Grabowsky is an internationally recognized expert on disease prevention and child health. Across his career, Dr. Grabowsky has held senior level positions at the World Health Organization, Center for Disease Control, National Institute of Health, American Red Cross, and Canadian International Development Agency. He has over 25 years of experience at the forefront of significant global health challenges, including efforts to reduce measles and malaria deaths in developing countries and advance HIV prevention strategies. At NIH, he was Chief of HIV Prevention Research and HIV Vaccine Clinical Development. At the CDC, he founded and led Global Partnership for Measles and Malaria Control, and has worked on disease control efforts in over 30 countries. With the UN's Special Envoy Office, he was responsible for directing strategic partnerships to finance the United Nations Millennium Development Goals. And as Deputy Director of the National Vaccine Program Office, he was on the National H1N1 Task Force and led efforts to increase flu vaccination nationally. His most recent position was as Chief Medical Officer at Pantherix, Inc., and he currently resides in San Juan, Puerto Rico. Old San Juan, to be more specific. Not to wanting to share your location, Mark, but we are very happy to have you and honored that you're spending some time with us. Thank you so much. And spotlight's on you. Thank you.
Thank you, Glenis, and thank you for the introduction, and thank you for the Philanthropia Puerto Rico for putting this presentation on. I'd like to start with a note of humility about what I'm going to present. Normally, as physicians, we understand that our knowledge has an expiration date. We usually talk about knowledge in the medical fields has a half-life of about 3 years, and every 3 years we have to replace about half the knowledge. And that's why we have to keep studying. And what's interesting about this disease is that the half-life of knowledge is about 3 days. And in fact, and sometimes it's 3 hours. And I wouldn't be surprised if by the time I finish this presentation, some of the data has been superseded. And so I'll be presenting data even as late as from this morning or last night, but with the understanding that is certainly not the final word on this data, and certainly that it will be superseded at some point, perhaps even quickly. So why do we care about coronavirus? And the reason we care is because of the mortality involved. And this is a graph from the New York Times published this morning, which shows the number of deaths by country since the start of each country's epidemic. And what we can see is if you look at those sort of faint background splayed lines of the doubling time, what we're seeing is the doubling time of mortality in each of these countries. In most European countries, between 2 and 3 days, in the US for about 4 days. Even in a country like South Korea, which has good control, the doubling time is about 2 weeks. And this distinguishes this disease from the flu in that if the mortality rate of this disease was close to what the flu was, we really wouldn't be having this level of concern. After all, we tolerate about 40,000 flu deaths each year. And so what's concerning to epidemiologists like me is that the mortality rate potential is much, much higher. And so it's the focus on mortality potential that's of interest for this disease. So for this talk, I'm going to talk about sort of 4 broad categories. The current situation in Puerto Rico, the high-risk groups for mortality, a suggestion about what Puerto Rican communities can do to address mortality issues, and then lessons from control of other pandemics. First thing to note about Puerto Rico is that it does have some factors which favor disease spread. It has the 3rd highest rate of urbanization, which we think facilitates contact rates. It has the 3rd highest rate of 65-year-olds, which we think is obviously a high mortality group. And it has the lowest per capita and highest unemployment rate among any states. And so these are factors which facilitate transmission in Puerto Rico and are cause for concern. These are the data from 10 o'clock last night by the Puerto Rican Ministry of Health. And what we can see is that there are 39 cases and 2 deaths. The chart at the bottom shows the evolution of the outbreak. On the far left is March 1st, in which there was first concern about the outbreak, first suspected cases, and the vertical axis is the number of cases or tests. The red bars show the tests and the green bars show the number of cases. What you can see is a constant increase in the number of tests. The 2 latest figures on the right are actually a Saturday and Sunday where we would expect fewer tests, but I suspect that on Monday and Tuesday, they'll rise up again. And the cases are increasing. What's interesting to me is the blue boxes, and they can show the actions taken by the Puerto Rican government. So within 2 days of finding the first positive cases, the governor acted quickly, and in my mind, perhaps faster than almost any other governor in the country or in the United States, with school closures and the cruise ship ban. 3 days later was the home quarantine, business closures and curfews. 3 days later was airport screening, and just last night, a financial aid package with cash grants to each Puerto Rican was announced. So these are remarkable and the effective interventions for this disease. Question is whether those will be effective or not, and we'll discuss that in this presentation. Of note, and these again are Puerto Rican country data, or Puerto Rican data, what we see is that this is the age of the current cases. And if you look at those who are 70 and above, they represent about 35% of the cases. So that's slightly higher than we're seeing in some of the states in the US. That may be because some of the first cases were among cruise ship passengers who tend to be older. But I expect that roughly this number is going to continue, but about 1/3 of the cases are going to be in older than 70. So this is the home isolation and quarantine in practice. This is a picture outside of my house at Calle San Sebastian, which is the center of nightlife of Old San Juan, on 6 o'clock on last Friday night, showing that it's completely abandoned when normally it's shoulder-to-shoulder crowds. And on the left is the box which all of us in Puerto Rico are familiar with, which is what comes up on our cell phones every night, which is around 8 o'clock p.m., which is around that the curfew is in effect, and the curfew is in effect from 9 o'clock at night till early in the morning. So my estimation is that community transmission is just starting. When we see a positive test that represents transmission that occurred, say, a week or two in the past, and the doubling time of these cases is about 3 days, it's likely that we have about 4 times as many doublings as cases that are reported. And so that looks like something like probably 500 to 1,000 cases are probably in Puerto Rico right now. But fortunately, Puerto Rico is about 2 weeks behind the US in actual case reports and about a week ahead in control measures because the government acted so quickly. So we have, I would say, about a 3-week window in Puerto Rico for additional actions before we start seeing some of the more steeper growth we're seeing in other places in the United States. So let's talk about high-risk groups. These 2 graphs are data from South Korea on the left and China on the right, which shows the percentage of cases that die by age group. And the first thing to notice is the shape of the curve, that it goes up to the right. And normally these curves for most diseases they're high on the left-hand side for the very young, and they go to 0 in the middle, and then they're high on the right-hand side for the very old. I call it a J-shaped curve. What's absent for this disease is that there's very little, in some cases, 0 mortality in the younger groups and a very high mortality in the older groups. And so in Korea, the absolute number is about 1 in 12 cases dies in the elderly, and in China it's about 1 in 7. So these are cause for enormous concern because these mortality rates, 1 in 7, 1 in 12, are enormously high for disease. They're about 10 times higher than what we're seeing for seasonal influenza. And these are the data from the United States, from the Centers for Disease Control, looking at the first 4,200 cases in the US. And we see a similar pattern with 0 deaths among those under 20, and a much higher rate in those who are elderly. Some of this is skewed by the fact that there was an initial outbreak in a nursing home in Washington State, and so a lot of the initial cases and initial deaths were in the elderly. I would expect this to come down slightly, but still that pattern is going to be striking about where the mortality is in the elderly. And if you look at those who are, say, less than 50, the mortality is really quite small. And we saw that in the, and I'll go back to the Korea and China data. If you look at those under 50 on the left-hand side of the graph, the mortality rate is really quite small. This is a problem of mortality in the elderly. Now, there is mortality in those underlying conditions, and there's an overlap, obviously, of the elderly and underlying conditions. And if you look at those who might die in a younger age group, most likely those are persons with underlying conditions. So what's the risk in Puerto Rico? Can we look into the future and say what this is going to look like? Well, here's one way to do that. We can take the age structure of cases in an outbreak in a country that sort of looks like Puerto Rico. And it turns out that Italy has about the same number of elderly that Puerto Rico does. In Italy, 22.7% are older than 65 years of age. In Puerto Rico, 20.2%. So they're kind of about the same. So we can take the distribution of cases. We also know the global case fatality rates by age, and we can apply those global case fatality rates, assuming that Puerto Rico mortality by age will be about the same as the rest of the world. And what we can see is, projecting that forward, is that about 88% of all deaths in Puerto Rico can be projected to be in those 70 years old or greater, with another 10% in 51 to 70 years, and essentially no deaths in those less than 50. So this defines where the concern in Puerto Rico is going to be, and that is those greater than 70 years of age are going to bear the enormous burden of this outbreak. So coming from this, it seems to me that the goal should be preventing mortality, and preventing mortality in the high-risk group, which is the elderly. And I'm going to talk about the roles of communities, but what I would suggest is a goal is that each community should adopt the goal of having 0 deaths in that community. And let me parse that in a little bit. So each community, while we usually think of community as being geographic entities, we can think of communities as being other social groups. So for example, I'm a member of a flying club here in Puerto Rico, and there's a lot of elderly members of that. It's a very much caring community that meets often. So we can imagine that community might be a community in which we could adopt each other and apply the upcoming principles to that. By 0 deaths, I mean 0 deaths to coronavirus. We certainly expect that the elderly will have high mortality from a range of conditions, but we're talking about 0 deaths from coronavirus. And by the elderly, the clearest data are in those over 70, but I don't mean to be strict about that. Certainly, one could look at younger age groups, and people with an elder person with underlying condition might be more severe than a younger person with underlying condition. So be a little flexible in that death. But generally, the key concept here is about community ownership of this goal. So let's look at the impact of strategies targeting the elderly in other communities, which during this outbreak, and what they've been able to accomplish. The first thing I'd like to show you is a modeling exercise that was done by Imperial College London and released last week. And they looked at what are the effects, what they called non-pharmaceutical interventions, that is basically behavior change on this outbreak. And this analysis had an enormous impact on thinking in the US, and it's sort of why the US government all of a sudden became much more serious about this outbreak because of the results of this model. And you can find this paper online. And these are the key findings of this paper. The graph on the left shows basically severe disease, and the boxes on the right show the overall impact on severe disease and deaths. And what you can see from the graph on the left, the black line, and it shows cases over time in some mathematically defined population. Basically shows if you do nothing, it reaches a certain height. And then if you sort of feed in specific interventions such as case isolation, or add in household quarantine, or close the schools, or add elderly specific interventions, you can see the effect of each of those. And if you look all the way at the bottom at the blue line, that blue line shows what happens if when you add into the case isolation and home quarantine and social distancing, which everybody is doing, you add in a targeting over 70s, you can see a dramatic effect. And in the boxes on the right, it measures that, and it defines these acronyms. CI is home isolation of cases, HQ is household quarantine, SD is social distancing, but the one that's of interest is this SDOL 70, which is, they define a special intervention for 70-year-olds, which is social distancing of 70-year-olds for additional time over the general population. So they define basically, this is a 3-month exercise on this model in England, but having an additional month in the elderly. And here's what they conclude from this report. Quote, the most effective combination of interventions to prevent deaths is predicted to be a combination of case isolation, home quarantine, and social distancing of those most at risk, the over 70s. In combination, this intervention strategy is predicted to reduce peak critical care demand by 2/3 and halve the number of deaths. And you can see in the box on the right here, right there, that it reduces peak deaths much more effectively when the over 70s intervention is added in than when it's not. And that is the additional intervention over 70s, in addition to all the other social distancing that the over 70s, everybody else is doing as their baseline. So let's talk about one population that tried strategies and see what effect they had. This is a publication by Harvard released last week that looked at the first 25,000 cases in Wuhan, where the outbreak actually started. And this is Wuhan, China. It's about 3 or 4 times the size of Puerto Rico by population. And these are the cases that they had. And the bottom line is the time scale, and the vertical axis is the number of cases, and each red bar shows cases by day. What you can see is around January 1st, they kind of got serious and closed the seafood market. Around January 10th was actually Lunar New Year, and so 7 million members of Wuhan, citizens, of the 11 million were traveling, either to Wuhan or away from Wuhan because of Lunar New Year, which is like Thanksgiving. Everybody needs to go home for that holiday. So an enormous effect on increasing transmission. So once they confirmed human transmission on January 19th, they started within a couple of days this dramatic isolation, both of the city and of the individuals in the city. And what they did was what we recognize now as social isolation that we're practicing, but to a much higher degree. Taking temperatures at every building, no driving in cars, only outside of your house for an hour every 2 days, really dramatic interventions. But what they found was that after a couple of weeks of that intervention, they had not been able to reduce transmission, that the number of cases stayed about the same. And the deaths were increasing in the elderly, so they added in targeted interventions, what we're calling a shift from sort of passive isolation activities to active isolation activities, actively knocking on doors, identifying people. And the point being that the passive measures in their minds didn't work and active measures were needed. So let me quantify how that worked. But first, little epidemiology lesson. So epidemiologists talk about the letter parameter R. And the R we use describes how fast an outbreak grows or declines. And R is proportional to 2 main factors. It's a little more complicated than this, but these are the gist of it. The first one is the number of contacts and the risk of transmission per contact. And so the number of contacts that a person has can be reduced by social distancing. And so if you stay indoors, you have fewer contacts, and that's how that number can then feed back into R. If you reduce your contacts by half, R should be reduced by half. And then the risk of transmission by each contact. And not all contacts are created equal. Some, if they take place over a longer period of time or involve touching, for example, that could be a higher risk. And so the way to reduce the risk of transmission is what we call a personal protection, or personal protection equipment feeds into that and reduces the transmission. So the 2 main interventions we have to reduce R and reduce the outbreak are implementing social distancing and adding in personal protection. So currently, we don't quite know what the R is. It's been sort of bouncing around a little bit, in different studies, and different countries report a different number. Some thought it was 2.2, then 2.5. Recent studies have shown it up to 4. So if we take an average of the numbers, it's about 3 right now. The goal is to have the R less than 1. If it's less than 1, that means the outbreak is falling and will eventually die out. So if you take this together, what we need to do to reduce current transmission, we have to reduce current transmission by about 70% to reach R less than 1. So some combination of social distancing and personal protection equipment has to be in place to reduce it to about 1. So going back to Wuhan, here's where they did an analysis of the R's based upon those interventions. And so on the left-hand side, we saw before they introduced any intervention, the R was 3.88, which is actually quite high, and you can see the steep rise of that curve. They then introduced these, what I'm calling passive interventions, which are sort of like what we're doing now. And it went down, the R went down, but the R stayed higher than 1, and the number of cases kept increasing. So once they realized this, they then introduced what are called these active measures, and then quickly they were able to get the R down to 0.32, below 1, and the outbreak has quickly been dying out after that. So it's this idea that A, we can measure and quantify these things, but secondly, that what may be needed is something more intensive, and particularly if you're concerned about high-risk groups, it may require something more intensive in particular high-risk groups. So here's one sample strategy to protect high-risk groups, which has been published by David Katz, who runs the Prevention Center at Yale, and you can find this online. And this is an adaptation of that. And basically, if you start at the bottom, everybody under the age of 75 in his model is the same. That is essentially lower risk if you have well-controlled medical conditions. And the two things are needed. You do social distancing and personal sanitation, which is essentially hand washing and staying at home. And that's the optimal strategy for that group. If you look in the middle, there's a second group, and that's the group that has close contact with the elderly. And those are caretakers, home health aides, and certainly medical personnel fall into this. And they need strict personal sanitation. That's why we talk about personal protective equipment, gloves, masks, gowns. And then secondly, they need a strict social distancing. And that's not just staying at home, but it's literally understanding that every person you come in contact is a threat, and staying close away from those people in a much more intensive way than we're doing now. So what he then talks about, the target group the group we're trying to protect with all of this, which is the age over 75 and those who have chronic disease. He talks about 4 interventions. Strict personal sanitation, usually involve wiping down the house, etc. Strict social distancing, and in this case, his proposal is that essentially zero contact. My mother is in a nursing home now, and she essentially stays in her room. She goes out of her room for 1 hour every 2 days. And she's happy to do that because she understands the risks of that, but that's the level of social distancing. And a number of nursing homes have now adopted that level of social distancing for nursing home residents. The third thing is the family distancing. And what we found, what was reported in China, was that about 80% of all transmissions to the elderly came from their family members. And so an essential component of protecting the elderly is preventing contact with families. And one of the ways to do this is that if any family member is suspected or tests positive, then all family members are equally isolated as the infected person. And certainly those people need to stay far away from the elderly. And then the shelter in place is this overriding issue of should not go outside. So this is his scheme to protect it. Now, one could adapt this for other communities, but something like this, and the point being that there needs to be a much more intensive level of isolation for those at higher risk than the rest of us are experiencing now. So there's some implications of this. And the first one is that they place enormous demand on the elderly and on their support communities. What we're saying is if you're not just the elderly, we just stay inside, you can't go outside, but we're saying that the caretakers also have additional burdens on them in terms of additional social isolation and additional personal protection. And secondly, the struggling communities cannot be successful with these extra burdens over time unless they have external support. It's just an unreasonable expectation, particularly these communities that we're seeing in Puerto Rico, which are among the poorest and high rates of unemployment that we're seeing from the US. So let's talk about lessons learned from successful global disease control globally. And this is not the first time we've seen a global pandemic. We've seen a number in the past, and there's a lot of experience from those. Let me talk about some lessons learned from those experiences. So the first one is about polio virus eradication. The first job I ever had in epidemiology was I was a fellow at the World Health Organization and was given the job in the immunization division of the World Health Organization, given the job of writing a pamphlet on community control of polio eradication. So how would communities act to eradicate polio? And sitting in my office in Geneva, Looking out at the Alps, I wrote this pamphlet for villages in developing countries about how they should act to control polio. I was then given the assignment of going to Vietnam to actually implement my plan. And of course, I quickly found that it was unworkable because sitting in Geneva, we had no idea of community relationships, community power structures, community resources, and most of all, community values. And so we quickly changed from a central-led directed community planning to community-based micro-planning. And what we found was when we went to community-based micro-planning, innovations emerged. That things that could not have been conceived of at my desk in Geneva were coming rapidly from these communities. And this has been formalized now in polio eradication around the world, about understanding that micro-planning from the village level up is something that is really the source of innovation in disease control for this global effort. So I think the lesson learned certainly applies to this disease where we know so little about how to control it, and there's much innovation to be done, and that innovation emerges when folks who are closest to the community are given the responsibility to do their planning on their own. Another example is something we learned from HIV. I was a medical officer at the Global Fund for AIDS, TB, and Malaria. And when HIV started, there was enormous support from governments, from NGOs, from aid agencies, from foundations. And what we found was that it overwhelmed local communities who were required for each grant they were to receive to write a separate plan, to figure out who was in charge, and to have a different monitoring and evaluation plan. And so even though foundations might give money for the same purpose, each foundation or donor was requiring their own specific evaluation, their own power structure, their own management structure, and their own plan. And so out of this chaos came the idea of the 3 1s. And this is the current way that AIDS control is practiced around the world. And so everybody who participates in HIV funding has to, in developing countries, has to participate in the 3 1s. And the one is that there's one agreed upon action framework, that everybody ties into the same plan, and that there has to be a consensus on what that plan is. And so, for example, if you're working in a community as an outside donor, you can't come in and say, give me a separate plan. What you have to do is be a part of the process that develops the overall plan, and then you can choose to participate in certain parts of that plan. The second one is there has to be one authority. In this case, they talk about a national authority, but it could be a county authority or a community authority. But really, the community has to decide who speaks for them. And the donors initially in HIV were standing up their own partners. They might well identify a person who they, for whatever reason, chose that person and stand them up as a leader of their process. And that caused enormous conflict. So the community has to identify and decide upon one person. And that one, or that not even a person, but an authority, it's usually a board, a group of people, and it has to have a multi-sector involvement. And finally, there has to be one monitoring evaluation system, which everybody who supports the program invests in, so they have one great system rather than numerous small ones. And the decrease in burden on the community level staff was the main outcome of this. Rather than having full-time staff doing nothing but writing grants and writing evaluation reports, they were able to have share those responsibilities and use those personnel resources for getting the work done. The third one is a little more slippery, but it's something we learned in malaria control. So I was head of a group that was delivering bed nets to every household in Africa. As of last month, we delivered 2 billion bed nets to households in Africa over about 10 years. And we had our micro plans and we had our 3 1s, And basically our idea was deliver 2 bed nets to every house. And then we would go back later, we would count to say how many bed nets were still in the house as our measure of sort of success. And what we realized was that rarely did households have the number of bed nets they were given, and our first impression was something nefarious was happening. They were being sold, or they were being who knows what. Well, once we investigated, we realized that 2 things were happening. One was that the households were giving out the bed nets as wedding gifts to their daughters. And because pregnant women are the highest risk group for malaria, distributing bed nets to newlyweds is a very rational process with great public health impact. And so we called this rational redistribution and understood that the communities knew what they were doing, and that even though they had agreed initially to a rigid plan, they had a better idea down the road. A second issue that came up of where the bed nets were going was that the communities were using them for fishing. And we actually did this investigation where we found out that what was driving this issue for misuse was basically poverty and food security. That the communities put a high value on eating as well as they did on malaria control, something we hadn't foreseen, but made perfect sense. And so what we then did was we paired up bed net distribution with some food security issues, and that allowed to solve both of those problems. But it's not something we would have thought of on our own, or even the community might have known about until the distribution took place. And so the lesson learned here is to be flexible in even after the intervention is well underway, because the communities might be have that innovation occur post-planning rather than pre-planning. So this is what the overall strategy would look like. Basically, community ownership of a goal of 0 deaths, intensive community service support to those over 70 and service providers, supporting the development of community microplans as the way to actually get this done, understand there's going to be local innovations, and that the donor community needs to have sort of a 3-1 strategy of planning, management, and monitoring to really allow this to be done efficiently and quickly. Let me end with this thought, and that is that in 1918, the flu pandemic was very similar to what we're seeing now with coronavirus. And New York City had about 30% fewer cases of deaths than other comparable cities. And a review of that was done, published in 2010, looking at, well, why was New York City had lower mortality? And it was investigators found that it was due to the leadership of the health commissioner, Dr. Will Copeland. And what he was able to do, and this is a quote from the report that you have there, but basically he was able to draw upon the network, the city civil society, social workers, labor unions, medical researchers, feminists, housing reformers, progressive activists of all kinds. And these, happily, this author says, are resources we have with us still. And so the idea of leadership to bring these resources together, it seems to me, is going to be one of the keys to reducing mortality. So thank you, Glenise. Let me hand it back to you.
Yes, thank you, Mark. That was fascinating, super insightful. I loved it. We're gonna open it up for questions. Like I mentioned at the beginning, at the bottom of your screen, you should see a Q&A icon, raise your hand or a chat, and we have one here. So what is the potential of mutation of the virus? If there was going to be a mutation, in what period of time could it be seen?
So 2 things about mutation. So as a technical point, these viruses mutate all the time. It's called a single-stranded RNA. It mutates all the time. And it's mutating now. The problem is that it's very, very difficult for a mutation to be, quote, an improvement or difference. So we're gonna have 2 things that happen. One is you'd have to sort of win the lottery and getting a mutation that makes it different. But secondly, even if it mutates, the original strain is still present in the society. So a mutated one would be a different strain. So just like we have HIV-1, and there's a mutation which led to HIV-2, HIV-1 is still circulating, HIV-2 is now a separate outbreak. So I don't think a mutation is going to have really any difference on the course of the outbreak, and I would be surprised. I wouldn't be surprised if there were mutations. I would be surprised if it made any difference on the course of the outbreak.
Okay. We have two more questions, and again, go ahead and put your questions in the Q&A or in the chat. So, Mark, how long do you anticipate this will go on?
So there's some clues to this, and obviously it's every country is looking at all their data and modeling it and trying to figure out where it's going. One of the clues is the SARS outbreak, which is a coronavirus. So that was SARS-1. This coronavirus is called SARS-2. Mm-hmm. SARS means severe acute respiratory syndrome. And that outbreak sort of started at the same time, around January. And that had two peaks, a Chinese peak and then a rest of the world peak. And it's sort of following the same path as this. And so it took about 3 or 4 months from January, so it was over by May. Much of the modeling now is suggesting that as well. But all of the modeling has hidden in it this idea that this is the initial outbreak, and that all of these viruses, such as colds and flu and others, tend to be less active in the warmer months and less active in the more humid months. So some of the models are showing that we might expect a rebound in the fall. Now, it also depends on what you believe about why this virus would go away at all. Mm-hmm. If you think about what happens with seasonal flu, we have in the US about 80 million cases of seasonal flu per year. That actually leads to a level of herd immunity in that the virus can't find a person who's susceptible. And that's sort of why it goes away. And that's in the case that we actually have flu vaccines. So we vaccinate about half the people in the country every year, even though the vaccines may be 60 or 70% effective. So we're really having immunity of well over 100 million people in the US, and that's why flus go away. If you believe that this herd immunity is why this virus is going away, then you have to accept that we're talking about over 100 million cases with this increased case fatality rate over flu in the elderly. It's unclear to me why it would go away in the absence of that herd immunity. I can see in the short term that we can do intensive social isolation and slow it down, have that sort of fading away by May. But where it goes from there is the worrisome part, and it's entirely unclear where it goes from there.
Good, thank you. We have a couple more questions, very interesting, by the way. You mentioned the shelf life of knowledge regarding COVID-19. Has there been any new light on immunity following infection?
Can you ask that again?
You mentioned the shelf life of knowledge regarding COVID-19, that, you know, everything's been changing day by day. Has there been any new light on immunity following infection? Once you get infected, are you immune to it, or could it go repetitive? So
the other coronaviruses produce lasting immunity if you get infected, and influenza viruses and the whole range of the single-stranded RNA viruses, of which this is a family, produce lasting immunity with infection. It's possible. We've done hundreds of thousands of tests now, and there are in those tests some people who have tested positive twice. The belief is that those are false positives. So the sense is that for all effects and purposes, all intents and purposes, people who recover have at least seasonal protection. We don't know how long it's going to last, but certainly through the course of the year would have protection.
Yes. Okay, another. Given that the U.S. is taking a very different approach to Puerto Rico, what should the island continue doing to protect ourselves from more lax measures outside of our waters?
So I really don't want to give advice to the government because I think the government's doing a great job and that's not really my role. But I could just comment on what's been happening. I'm really impressed with the scientific excellence and the compassion of the Puerto Rican government, what they've been doing. I mean, trying to immediately cutting off cruise ships, screening at the airport. They're trying to cut off flights to the island, but there are reasons why you can't cut off flights within the US territory. So my sense is that the things that a government can do, this government is doing, but that may not be enough. And it may be that civil society needs to take on the rest. But I don't think the threat to Puerto Rico at this point is importations. Right now, a reasonable estimate is there are several hundred, if not, several hundred cases already in the island. I don't think the introduction of several more through importation is going to be what drives the outbreak.
Good. And so I have a couple more questions. I'm gonna lump them together because they might be similar. Okay. So I have one. This might not be, you might not know this, but just in case. What is your assessment of the capacity of the medical system in Puerto Rico to handle what is expected?
I'm going to defer on that. I don't have any special knowledge on that.
Good. So I'll give you another one. Considering current local factors, including social distancing and inferences made for global pandemic, when should we expect a peak in transmission in Puerto Rico?
So my sense is that Puerto Rico is about 3 weeks behind, 2 weeks behind in transmission and about 1 week ahead in response. So both of those work in the favor of Puerto Rico of having a lower peak and a later peak. So if we apply that to what we're seeing in New York, which we think is going to peak in about 3 or 4 weeks, which the governor said this morning or yesterday, Puerto Rico can look at being few weeks past that, so maybe 8 weeks. So I'm just sort of speaking well beyond the data at this point, but I would think that that would be a reasonable expectation. One of the problems of having effective control, though, is that you have fewer cases and therefore fewer immune people in the population. And so that allows more fertile ground for the virus to find susceptible people. And what we're seeing now in, say, South Korea, which has a great control program, is the cases are continuing on over some time. I guess the question is what's the signal for stopping isolation and other community-based measures? Is it a single case in the country? Is it below a certain level? Is it control in high-risk populations? We don't know. And so going a little bit beyond your question here, but my suggestion is that where this is heading is that I don't think the population-wide control measures are going to be very effective and may not be needed. But what's really needed to prevent mortality are intensive measures in those who are at high risk. And I think that's sort of where we're going to be heading.
Right, and that was your recommendation. I want you to share the previous slide that has your recommendations. I have a couple more questions for you. So can you...
This one?
Yes, your proposed strategy. I want to finish kind of with that, but I have 2 more questions. Can you speak on hopefulness for vaccine research?
So I've been in vaccine research my whole life, and I've been chief of vaccine development at NIH, where the vaccines are one of the places the vaccines are being made now. 2 things. One is it takes time, and it's probably going to be a year and a half. We can get lucky. If the vaccines are highly effective, it's easier to tell they're effective, and if you guessed right to begin with. We often said with HIV vaccine development, if we had the vaccine in our pocket today, it would still be 3 or 4 years before we could put it on the market. So I would think that if we have all hands on deck and really accelerate, we're talking 12 to 18 months. The problem is this: we don't have any effective vaccines against coronavirus at this point. And we have no vaccines using the technology that they're using for these vaccines, which are sort of called a messenger RNA vaccine, which are very cheap, very easy to produce, rapidly able to produce. But there are no licensed vaccines made from messenger RNA, and there are no licensed vaccines for any coronavirus. So we can get an answer on whether the vaccines work or not within a year, but it's unclear what that answer is going to be. So to me, I'm skeptical that a vaccine is going to be in play for getting us out of this outbreak. I would also note that we have flu vaccines every year. Mm-hmm. And the rate of flu vaccination in the US is about 40%. It's higher in some risk groups. And so the enthusiasm for the population to get vaccines is actually quite low. Remember we had the H1N1 pandemic several years ago. We had the H1N1 vaccine and a national effort to have H1N1 vaccination. The uptake of that vaccine was actually quite low. And so I wouldn't assume that even if we had a vaccine that the population would enthusiastically embrace the vaccine. That hasn't been my experience. So A, the technologies are unproven. B, we don't have any vaccines for this type of virus. And C, it's unclear to me about how we would actually achieve high coverage rates.
Good. So I have two more questions that I'm going to join into one, and we'll give it a close. There is one comment that says, for a researcher, can you suggest references to modeling done to understand the virus? And we could probably share those in the recording of this if you have anything to share.
There's actually some that came out today from Italy, in fact. So they're coming out rapidly. I can after this call, I can share them with you, Glenise, and you can send those out.
Good. Oh, just one question came in. Don't we have effective coronavirus vaccines for dogs? What is the difference? I did not know this.
Yes, we do. That's a great question. We have a couple things. One, it's easier to test in animals, and we tolerate more side effects, and the biology is different in dogs, and the virus is different in dogs. So. And the disease has a financial interest in vaccinating. So those are the issues. But there's a range of different host microbe interactions that are different between dogs and people. But it certainly does give us hope that we can do that. That technology, though, is not the mRNA technology that we're testing for these vaccines. It's a much more traditional technology, which takes much longer to develop than the technology we're using for this coronavirus.
Okay, good. But good to know my dog will be safe. There's still questions coming in. So one question, which are key sectors in Puerto Rico to get involved? And I'll add it to other, which are key sectors in Puerto Rico to get involved? That's one question. And then, for families living in poverty, there is now the risk to work and become ill, spread the illness, but also the economic risk to not be able to work. What should people and/or governments be doing to ensure people stay healthy and do not fall further below the poverty line?
So this is sort of outside my area of expertise, although I would note the government has said they're delivering checks this week, I think, to the public. The larger question that's being asked, I think, is what's the most direct method to bring this outbreak under control so these burdens can be lifted and people can go back to work. And obviously the poor always share these burdens greater than the wealthy. And anybody who's living day to day is now suffering enormously from not having.
Yeah.
So I would suggest that some strategy, and this is my personal opinion, which focuses on the high risk and relieves the burden from the general population or reduces the burden of the general population is probably where this has headed, just for the reasons that that questioner cites, that the burden on the population, which again is generally at low risk from the disease, is enormous. And so I think where we're headed is that. And in terms of bringing communities together, the first part of your question, I think that there are other experts around who are much better able to answer that question than me. But I would say that that's essential. That's the essential question: is how do we bring multiple members of the society together to solve the problem?
Yeah, and I think that's the magic of this pandemic. And if we want to see that, this is the opportunity. This is why we also bring these webinars to influence and spark these conversations. I have one last question that just came in. Is there capacity to develop an immunity test?
So the immunity test exists. It's being used in South Korea and China, I believe, and it's a test, what this questioner might know is an antibody test, and it measures whether you develop antibodies. Same test we use for, say, measles, for example, where we measure the immune response, either IgM or what we call IgG. Those exist. They're not licensed yet in the United States. They answer a different question than the PCR test we're using now. Instead of answering the question, do you have active virus, they answer the question, have you developed an immune response? And I think for most of this currently now, we're asking for, do you have active virus, which means you're a threat to infect others. Having an immune response is important though. For example, if you're a healthcare worker, you want to know if you're immune, or if you're a caretaker of a risk person, you want to know if you're immune. So those tests exist. They're being worked on in the US, and they'll probably be available, but people should only use them to understand what is the question we're trying to answer here. And for some of those questions, that's the right test. Beautiful.
Thank you, Mark, for this insightful talk. It was wonderful. I loved it. I loved how you put this proposed strategy together. I do also want to point out that in Puerto Rico, one of the funders, Fundación Comunitaria, Community Foundation of Puerto Rico, is following this proposed strategy in their response to the COVID. So we could have further questions for them and any support. Again, thank you. I don't see any more questions. We have put on the chat a link for you to give us feedback. We want to get better on these webinars. We also want to hear what are the things you would like to hear about and discuss. So please go ahead. It'll take you 3 minutes to just fill out. We will share this presentation and any other links of research that Mark will go ahead and share with us. We'll pass those along, as well as the presentation. You can find that in filantropiapuertorico.online. And for next week, we'll probably continue this conversation of COVID-19, more focused on the government response. We're still cooking that, so you should get an email into what is the next webinar. But thank you so much for being here. Have a great week. Stay safe. Mark, thank you so much for your time and your insight. And thank you so much. We'll be sharing his information, Mark's information as well. So thank you. Have a great one.